which procedures do you focus on the most?
The thing I get asked to do the most of is usually breast surgery.
What kind?
It pretty much everything. So early in my career, it was mostly reconstruction.
Okay.
Um,
Cancer patients.
yep.
And okay.
And then, over time, more and more patients came with cosmetic problems. So whether it was somebody getting implants for the first time or somebody who had old implants that wanted to change them, people who had implants that had leaked, people who had hardening of the tissue around their implants called capsular contracture, breast reductions, breast lifts, just the full gamut.
Welcome to Care Experts, a podcast dedicated to empowering you with knowledge for your health and self-care. I'm Melissa, a broadcast journalist.
And I'm Selah, a former fitness coach and personal trainer.
Each week, we interview top wellness and medical specialists from across the country, addressing your questions, even those you might be afraid to ask.
From your fur baby's well-being to skincare secrets to honest talk about bigger health issues, get it straight from the expert.
Join us every Wednesday for insights that will guide you on your health journey.
From cosmetic to dental and vet to vision, this is Care Experts. Today we are talking about everybody's favorite subject.
Is it?
Well, a lot of people's favorite.
A lot of people.
Breast augmentation.
Breast augmentation.
Yes, implants, reconstruction, so much more.
And you know what? I feel like now we're in a phase of life where we're like, I'm open to it.
Yeah,
I mean,
after
about
breastfeeding 3 children,
Oh,
yes.
honey, I just had the one child, and I'm just like, oh, let me see what's out there.
Yes.
And you know who's going to be the expert to tell us all about it? It is Dr. Justin West, who is a board-certified plastic surgeon. He'll be joining us to talk about breast augmentation, reconstruction, and everything you mentioned.
I'm so excited to hear from you.
Me too. Dr. Justin West is here with us.
Hello.
Welcome, Dr. West.
Thank you for having me.
Thanks for being here.
That's great.
You are a board-certified plastic surgeon
Indeed.
out of Orange County at Finesse Plastic Surgery.
Yes.
In Orange?
In Orange.
Oh,
in Orange County.
Right, Orange and Orange County. Hello.
You're the medical director of Finesse Plastic Surgery,
I
to be
am.
specific, right?
Yes.
And your emphasis is on the face, the body, and the breast.
It's evolved over time. So
Oh,
I would
okay.
say these days it's mostly breast and body.
Okay.
I think it's really challenging to be an outstanding surgeon from head to toe. So over time, you typically would find that a lot of surgeons will find something that they're really good at and just focus on that. I still have colleagues who try to, who like to do everything because it makes your career more interesting when you can kind of shift. But I just decided to focus on one area for me, breast and body, and just sort of push that evolution in terms of the skill, as much as I could. It's a lot of responsibility to be outstanding at eyes and outstanding at faces and outstanding at necks. And, it's a lot of areas to operate on. And the techniques are so specific. So, no, breast and body.
Yeah, and today we're talking mostly about everything about breasts, whether it's lifting, reconstructing. Can you just walk our audience through what is a breast augmentation?
Yes.
So, pretty simple, right? It's making your breast larger, which is typically going to be done with an implant. There's other ways of doing it. You can also use fat grafting. There's some reasons why I choose not to do it that way for the most part. But breast augmentation is making breast larger with silicone or saline implants.
And those are the only 2 types
Right
of
now,
implants,
those are our 2 options. Or again, like I said, with fat grafting. So if somebody comes in and they have some extra fat where they don't want it, you can liposuction that fat, and instead of throwing it away, we can graft it. The reason I typically don't, I think, really is because of the time I spent doing reconstruction. 1 in 8 women get breast cancer.
1 in 8?
Yeah, it's a pretty
I
big number.
realized
That is
Yeah.
startling.
So which is a scary stat to be looking at.
Yeah.
And I've taken care of patients from 28 to 78. And so, if you are going, when you start a mammogram, it's a little bit controversial. So usually people start anywhere between 40 and 50. I'm a big fan of 40 because I've seen just too many younger women develop breast cancer. So imagine every year you're going to get your mammogram, and all you're hoping is that it doesn't find anything.
Exactly.
Right.
But if you do have a cancer, you really want to hope that mammogram finds it, as opposed to missing it and then it grows for a year and then maybe you miss it again and it continues to grow. Because all the data shows the earlier you catch it, the better your survival. When you get a mammogram, what they're looking for masses and they're looking for calcifications. They're looking for these indicators that something is there. So calcification occurs around a developing cancer. Calcifications come in different appearances, right? So the calcifications typically associated with breast cancer have a very distinct appearance. Fat grafting, when we fat graft people, right? We liposuction somebody's thighs, their back, whatever it is. We can inject it to your face. We can inject it to your breast. when you inject it, no matter where you inject it, some of the fat dies. And when it does, it creates a different type of calcification. Okay. Now, to a radiologist, if you just say, here's one white spot that's a calcification and one white spot that's cancer, if they know the difference, it's like us knowing the difference between red and blue.
Oh, okay.
Okay.
But if you're looking out into the the sky, right? Let's say you're in the desert somewhere that doesn't have any air pollution. You've got a beautiful night sky with all the stars you can imagine. Most of the, imagine taking all those represent normal calcifications from let's say fat grafting, right? It's not a pathological type of fat or type of calcifications. Now you throw in an abnormal cancer. What you want to do is look into a totally black sky and see one calcification that's cancer. If you take a sky that's full of fat graft-induced calcifications, these millions of little particles, and then hide a cancer, it's just going to be harder to find.
Much harder to detect.
So my philosophy is you want it to be as easy as possible to find cancer, and don't confuse it by adding fat grafting, which is inevitably going to lead to some amount of calcification and make it a little harder to find a cancer. So if it's my daughter, no.
I see.
And I don't like to do things for patients that I wouldn't do for my daughter.
Oh,
There's
for your own
nothing wrong
family.
with it.
Yeah. Right.
And I wouldn't at all say that surgeons are doing the wrong thing.
Sure.
But as somebody who lived for a very long time in the cancer world, I would never want somebody to do something for my daughter that would hurt her chances of detecting a cancer.
Right.
And I think it's hard to argue that it doesn't.
Dr.
Right,
West,
that
you
makes
talked about with breast augmentation. So
Yeah.
if you're not doing the fat grafting,
Yeah.
then you really have two options, silicone or saline.
Yes.
What's the difference?
Well, I mean, at the end of the day, you're adding a fixed volume to your breast, right? So you've got a device. Some of the differences. Saline implants come empty. We fill them up to an amount of saline that the box says we can fill it. So each implant has a range. You can put implants in anywhere from 100 cc's to 960 cc's. And if you don't want to worry about the warranty, you can fill it to whatever you want.
Breast implants come with a warranty?
Yeah.
Yeah.
I didn't know that.
Yeah, so lots of things to talk about. We
Yeah.
can talk about 960 and what do you mean you can fill it to whatever you want. We can talk about warranty. So yes, they're warranted now. So, and I think they do that to give patients confidence.
A little bit of peace of mind,
So
too.
implants, because all patients know at some point they can rupture. And
Sure.
then the question is, well, what happens?
Right.
Well, we have to replace it, but the good news is implants are now warranted. So, and it's different warranties from different companies. They it's different from saline versus silicone. But for a silicone implant, they're warranted for life. So if you have a rupture, they give you 2 new implants because the assumption is you might want to change both.
Yeah. You're already under.
And in the first 10 years, I think the current most of the current warranties for silicone are that they will also give you some money towards the surgery. But it's free it's new implants for life for that first surgery that you have. Then there's a warranty for capsular contracture, which we haven't really talked about yet. But the bottom line is for the common complications we see, the implant companies are now owning that and saying, hey, to give you more confidence, we're going to warranty against the common complications, which is pretty cool.
Yeah, that's
They didn't
really
do that
great.
years ago.
Okay.
So I think it helps to reduce fear in terms of the bar for entry. People can say, okay, well, what if I have to do this twice? Well, the odds are you are, unless you're 90 getting implants.
Right.
You're going to outlive your
Isn't it
implants.
every 15 years or something
Oh, I
like
thought
that?
it was every
Okay, so
10.
there's
Oh,
another-
debunk that myth for us, please, Dr. West.
So
How
there's
often do you
nothing
get-
that says you have to have surgery every 10 years, but the data does show that on average, the average patient gets about 10 years out of their implants before they elect to do something. So the reasons that people would have a second surgery, they decide they're too small, they decide they're too big, they have a rupture, the implant drops too low, drops out to the side, or you get this hardening process where the scar tissue around it tightens and gives you capsular contracture. So that's the whole host. Or people just decide, you know what, I don't want them anymore, which happens.
Okay.
So there's a variety of reasons why people elect to do surgery, but you don't have to. I mean, implants don't magically become dangerous at year 10 to the point where you
Oh,
have
they
to-
don't.
No,
okay.
I
No,
thought
where
I
you have
heard
to
that they're
run
like
in and-
toxic after your 10.
Right, like they have
the
an
long-
expiration date or something,
Yeah, I mean, look, the longer they're
Best
in,
buy date.
That's fine.
the longer they're in, the more likely you are to have a problem with them, right? So,
Yeah.
if you have a saline implant and let's say it ruptures, the beauty of saline, if going back to the whole silicone versus saline is nice in the fact that if it ruptures, typically it just totally deflates, your body absorbs it, and you wake up one day and say, oh, I think I need a new implant.
Wait,
Sure.
really?
Yeah,
So
your body
what if
absorbs
like
just
just
like
one is deflated? Does
Sorry,
that happen a
Captain.
lot? Just one is
That's
deflated?
usually what happens.
Oh, yeah.
It would be very unusual to wake
Yeah,
up and have 2 deflations on the same day.
Right. That would
Someone
be like,
did something to earn that,
go
right?
play the lottery.
That means
earn it.
somebody,
Something happened.
something happened to this
Sure.
person, or they were doing something kind of silly, But I've actually never seen it, unless it's, well, I had a rupture a year ago, decided not to do something, and now all of a sudden this one's ruptured. But it'd be highly unusual to have somebody wake up one day and say, "Wow, what happened? They're both deflated." With silicone, you don't absorb silicone. So you could have a rupture, and there's thousands of people right now walking around with ruptured silicone implants who just haven't figured it out yet.
Oh.
But they don't magically become toxic. There's lots of people who have. Now, is it irritating to tissue? Sure. Can you have some problems from them? Sure. The longer it sits there, could it be more problematic? Yes. But people don't come in on a Monday, we find out they've got a rupture, say, oh my gosh, we have to deal with this
have to do
tomorrow.
this immediately.
We always recommend that they get changed, you either remove them or change them, but it's not an emergency.
Like I had a friend have a lump on hers. Is
Sure.
that normal? Is
Well,
she
it depends. The way patients describe things is not always how we might describe
Oh,
something.
okay.
So, but when you say that, sometimes what we see when someone describes that is this: some silicone has gotten out of the shell, and it's now irritating the tissue, and it's kind of creating. You get this granulomatous reaction. Just imagine just like a scar reaction to it, where it annoys the tissue, and so it can appear like a mass next to the implant, or it can actually just be the silicone itself. So the radiologist, you get a mammogram or an MRI, and it looks like there's a little mass next to your implant. Well, it's silicone, older silicone, that leaked out of the shell and is now accumulated between the shell and the breast tissue, or within the breast tissue. The silicone today is more like Jell-O, so it doesn't migrate the way the more liquidy silicone from, let's say, 15, 20 years ago did.
Obviously, you do implants for cosmetic reasons, but you also talked about doing them for breast reconstruction for cancer patients. How does that work, and how do you feel after doing that for someone, bringing them, back
Making
to
them
their
whole again.
Yeah.
Yeah, well, that's exactly how I think about it. You're making someone whole. You're restoring their confidence, their sense of femininity. It's transformative for a lot of these patients. And the issue is that, back in the day, a lot of patients would have a mastectomy and no reconstruction, and so they would wake up, look in the mirror,
Oh my God.
and they would, they're met by something they're not really prepared for, I think, emotionally. And then they would have a reconstruction and really see what the reconstruction did for them. These days, we tend to do the reconstruction at the same time.
Wow.
Whether it's putting the implant in immediately or putting a tissue expander, which is a temporary device while we're waiting to stretch the skin back out for their implant. So fortunately, women don't have to go through that same very aggressive change.
Very
Some
jarring, I'm assuming.
And have to wait to become transformed.
Yeah.
Now they can do it all.
So, now if they lose a nipple, there's a loss associated with that, right? That they're not, maybe always prepared for. We can usually restore that by doing a reconstruction. But these days, by the time I, I slowed down reconstruction quite a bit recently.
Okay.
But, in my generation, most of our women were going through surgery having their nipples spared, where all the skin was there, and we could get either the entire implant in or at least 80% of the volume they needed immediately. So it was not unusual for us to have patients come in saying they actually like their breasts more after their
I'm
reconstruction
sure.
than before.
They're brand new.
Right. And a common story would be, I never would have had cosmetic breast surgery, but I'm glad I did this, and I feel really good about it. And again, maybe 20% saying I actually like myself better now which is a very cool thing to be a part of.
Well, that actually leads me to my next question. Selfishly, I would
ask it.
really like a lift after breastfeeding 3 babies.
Yeah.
Is that common?
Oh,
People
sure.
just wanting a lift. I don't need an implant.
Here's kind of how I process it, or I'll ask this question, patient. So if a patient comes in and says, I really like my breast size, I like how it fit in clothes, I like when I look in the mirror, how
Right.
my breasts look in a bra, but not what I look like when I take my bra off.
Exactly.
That patient's usually going to be a good candidate for a breast lift.
Okay.
You're just redistributing the volume they have to a higher position. You're getting,
Yeah.
if there's breast sitting on the top of your belly, you're getting it up off of your belly so that you can actually, when you look in the mirror, you can see the bottom of your breast again. For people whose nipples or the areolas have dilated and they've dropped too low, we get it back in the middle of the breast. We lift up the nipple. We can make the areola smaller, lift up the nipple to a higher kind of a perky, more youthful position. And
What?
Yeah.
Amazing.
I
Now-
mean, you said selfish for you, but I'm like, really? I have had a child and him suffering the effects of that as well. But go on,
Right.
Dr. West.
Well, whether it's from kids or aging, right? It's
Sure.
very few women get to look in the mirror at 60. And we do see this sometimes where the breasts haven't moved. Some of those patients come in like, wow,
What?
like how did that happen? And then we have patients who are 20 who've never had kids. they've never had a weight loss issue or weight gain issue, but their breasts they don't have the same support structure that somebody else might have.
The elasticity.
So it's, kids can be absolutely are a common part of the equation, but not always.
That's
Sometimes
true.
it's just, it's the anatomy that you're born with. And then, so in terms of, the implants versus lift, we do have patients who come in who have sufficient tissue to do reshaping and get a great result just from a lift.
Okay.
Then you get patients who have 2 or 3 kids, sometimes it's just one, where they have a lot of loose skin, they lose most of their breast fat and breast tissue, and they're really deflated. And you can move the skin, but there's nothing to fill out the breast. So for those patients, it's typically implants plus a lift.
Okay.
Sometimes an implant alone, but usually it's implants plus a lift.
That makes sense.
And then there's the next patient category, which is the patients who come and say, I have too much breast volume in a bra. I need less.
Yeah.
And that's the reduction pathway where we take tissue out to make a breast that they feel gives them better shape and proportions.
Which can also be so transformative. I've had
sure.
several friends and family members get reductions, and they can walk, they can hold themselves up. They don't have back
Their
pain.
neck isn't hurting as much. Their
Yeah.
back isn't hurting as much. Let's just start from the beginning, though. What does a breast lift entail? What is it?
So the way I think about it, it's like tailoring a dress. You're reshaping something. So if you lose 30 pounds, your dress suddenly doesn't fit you, right? It's like
Yeah.
you're walking around in somebody else's clothes, and you either buy new clothes or you go to your tailor, and they take that dress and they make it fit your body. A breast lift is like going to the tailor and saying, "Hey, can you make my dress fit again?" So you're taking out extra
great
skin.
Yeah, that's a great analogy.
Yeah.
You're
Dr. West.
redistributing, right? Like a push-up bra would redistribute, but we're giving you essentially a surgical push-up bra. We're taking out the extra skin that doesn't fit you anymore, making a more compact breast with a better nipple position. So you're kind of recreating a more youthful appearance. So it's not making you look like somebody else. It's usually making you look like what you did 5 or 10 or
Yes.
15 years ago, which people like because they can look in the mirror and say, "Oh, that's
there she
me. That's the
is.
version of me I really like."
There
Is
she
it
is.
painful afterwards, or
it's-
what's the
it's-
recovery like?
Yeah,
With
that's
just
really-
the lift.
Yeah, so let's divide those because
Yeah.
they are
Okay.
different things.
Yeah, exactly.
So breast lifts, I would say most people do incredibly well. So
Okay.
the cutting and sewing is done at a fairly superficial level. We're not getting into muscle, which is usually what hurts patients. So we have patients that we routinely give patients pain medications, but the vast majority don't take any narcotics overnight. They're fine on Advil and Tylenol. And they're usually shocked by how well they feel. So it's a pretty easy recovery. Now we do put restrictions because we want you to heal well.
Of
Yeah.
course.
But in terms of the recovery itself, people are usually very underwhelmed
Okay.
by the recovery process.
Great.
So we have patients, you could do this for a lot of patients depending on what kind of work they do. But that is a surgery you could do on a Friday and have a lot of patients go back to work on a Monday. Now, that being said, I encourage patients, hey, if you can take a week off, take it.
Yeah.
2 weeks would be luxurious and not necessary. And then you get patients who say, okay, when I get a cold, I like to take a month off and sit in bed. Most patients, they're on their computer that night. They're sending out
my
emails. Like
gosh.
some people just can't help themselves. They're going to
Okay.
work. And this is the time, so unless you're a FedEx driver or something where, you're an MMA fighter, where you're doing something where there's a lot of
Sure.
movement, most of our patients can get back to their version of normal pretty darn quickly.
Oh, that's cool.
How much does a breast lift cost?
Okay, so here's the answer. The answer is it's kind of complicated for a variety of reasons.
Okay.
Number one is where are you doing it, right? If you're practicing in Southern California, where there's a certain demand and there's a certain cost of living,
Sure.
you have a high density of really good plastic surgeons, it's usually, it's not inexpensive.
Okay.
Right.
You could do that same surgery in South Dakota where the cost of living is much lower, the surgeon's overhead is much lower, and it might be a much more reasonable number. And then even within the same zip code, you have people who think very highly of themselves. And now, do you sometimes see a difference in the outcomes? Sometimes. But, sometimes the difference is you just can't explain with outcomes and skills. So, it's highly variable.
Ballpark for you. Let's say I booked an appointment with you and I just wanted a simple.
needs to budget this.
So here's my
I'm just budgeting in my head.
Here's
You're
a
a friend.
So here's my very embarrassing answer. The truth is, our policy is always separating the two. So I don't talk to patients about money. Once or twice a year, I'll sit with my staff, and they'll call other offices, see what people are charging, and I typically kind of sit in the upper 5th percentile of what people will charge.
Okay.
Alright.
Because I'm happy to explain why.
Okay.
But then I stop thinking about it. If patients ask, I say, look, that conversation happens when I leave the room because I don't want to have that. Ask me anything medical.
Sure.
And then I have people who don't do anything medical in the office who really handle the finance questions.
Okay.
I just think they shouldn't be blended. So yes, here's a very generic answer I'll give you. Everything we do is expensive, right? So some of the things we do, it's like buying a small car. Some of it's like buying a big car. Depends on what you're doing. And for most patients, I mean, for me, if I walked in and a colleague gave my wife a quote for something, or me, but I'm too scared, I'm kidding, I would say, whoa, I'm going to have to really think about that. And
Sure.
plan
Yeah,
it,
of
and
course.
how does it fit in the budget? And we've got
Yeah.
mortgage, cars, kids, tuition, all these things.
All the things.
They're not small numbers. I mean, we get incredibly successful people who come in and say, look, it's a substantial amount, and people don't have a frame of reference. But if you've been buying
True.
if you've been buying
Yeah.
cars your whole life, or you have a sense like, well, my Honda costs this, and
That's
then
a
I got
good
that,
point.
right? Most people don't have a frame of reference when they
That's
walk
true.
in. Like, I don't know what breast surgery should cost.
Yeah.
Right.
And you don't see on TV. Oh, the Honda dealership's having a sale on
No.
Monday.
Yeah.
So
It's a really good point.
It's a strange conversation for people who don't have have a background in it. But yes, so I would say the vast majority of people have to really think about it, regardless of how well they do financially. And most people don't just walk in with a suitcase full of money.
Yeah.
So it's either sometimes that happens sometimes.
Sure.
definitely, But usually it's it's credit cards and it's checks and it's hey and then it's financing. So CareCredit comes up a lot, and the beauty of that is there's patients who walk in that are lovely humans. They have really reasonable, realistic goals, and you can make a big difference for their confidence, for the way they present themselves in clothes, the way by doing a procedure.
Yeah.
And you educate them and empower them to make good decisions, and then you realize, okay, the financial part's going to be a big factor, and then you feel guilty thinking, well, should I do this? How can I work?
I want to help them.
Yeah, but
Yeah.
the problem is you can't do that for everybody, and you have overhead, you've got staff, you've got children, your family,
Yeah,
whatever.
Sure.
But CareCredit sort of is like in some ways the great equalizer, right? So that that procedure doesn't have to be only available to the upper 1 percentile or actors and investment bankers and hedge fund managers. You can make it accessible, and you don't have to compromise the plan.
Yeah.
Because the
that
other
part.
version is to say, well, here's a 6-hour surgery, and that's what's going to give you the result that you've just told me you want. You've shown me the photos, and I know what it's going to take to do that, and this is the right plan. But then you start peeling back and say, well, if we don't do this, and if we don't do that, then what happens is they still have in their mind that picture.
Oh,
That final result.
Now you've done a third of that plan, and no matter
Yeah.
what I say to explain it in advance and to prepare them for a realistic outcome, that nothing changes that goal.
That's such a good point.
And so you're handing them a compromised plan. So in your early days, you say, okay, I'll do that, and then you go through that experience with the patient. You're like, I never want to. So what I typically do is say, this is what you need to do. Unless you change your goal, this is the plan it takes. And if we don't do that, I'd rather you either don't do surgery or find somebody else, because I think it's going to compromise your outcome, because what you're asking can't be delivered with the version of the plan you're asking me to do, because it's less expensive.
I see.
So I try not to do that.
Yeah,
Like if somebody needs implants in the lift, don't just do the implants. It'll look terrible.
Oh, yeah.
If they need implants in the
goodness.
lift, don't just do the lift.
Right.
Yeah.
Because they're not going to get the result. You have if they show you a result and they need these two things, do those two things or don't do it.
Yeah.
So you're honest in the consultation about this.
Brutal.
If this
Yes,
is what,
you
brutally
have to.
honest.
Look,
You have to be.
I educate my patients the same way I would want to be educated. I would expect my children to be educated,
Sure.
my wife, my friends. I think that our job, and in some ways it's the hardest thing we do, is to appropriately educate and empower patients to make decisions. And sometimes that means some patients hear that and it's too much, and it scares them.
Yeah.
But I think that if that happens, I've done us both a favor, because if they hear that and they can't handle it, they shouldn't have surgery. If they hear that blunt version and say, I get it, and then they choose me, I know we'll get through everything just fine.
That's so good to hear.
Speaking of patients that get a little scared or timid,
Yeah.
are there non-surgical procedures like the laser breast lift, or what do you think about those? And do you even do those?
No.
Okay.
I think that there are, and I'm not saying anybody who's doing it is doing the wrong thing. Everybody gets good with the techniques that, to some degree, right, on their own, right? So if you decide you don't want to be a surgeon and do invasive procedures, you might spend a lot of time figuring out, how do I optimize the best tool on the market to get the best result I can? So there's going to be some, technicians, surgeons, whatever they are, who can really get the most out of a certain device, because they just, they figure out the perfect settings. And then if you have that skill set with appropriately selected patients, like a lift for somebody who doesn't really need a lift, or a really small lift, maybe that's all the patient needs. But nothing is ever as powerful as surgery. It doesn't matter if it's the face. You can talk about threads and vampire lifts and all these other things, but nothing, just like face, just like breast, just like body, nothing is as powerful as surgery. If somebody comes in and says, I will not undergo a surgical procedure, but how can I tighten up the skin on my belly? Okay, here's what we can do.
Well, here are your options.
But here's the caveat. 25% of people see no result, 25% see a fair result, 25% see a good result, and 25% see, I don't know how many percents I've just added. Something 100 to 125.
125%.
Whatever we're at now. But but
I get what you're saying.
it's a distribution of everything from nothing to something that might be pretty good and everything in the middle, and it's still not inexpensive.
Right.
And so if you're the kind of person who can spend $5,000 to $7,000, let's say, for like an area of body tightening and afford to say, hey, if it doesn't do anything, I'm okay with that. Okay. But if you spent a year or two saving that money and hoping and dreaming about what it's going to look like and how it's going to change how you feel in a bathing suit when you go on, to Hawaii next year, whatever you're doing, and then you don't get it, we're setting you up for, disappointment. So some people can eat that, no big deal. Sure, I'll try, and if it doesn't work, no big deal, and I'll come back to you for surgery later. All right, fine. That's a relationship we could have, and that's reasonable, and I'm not going to disappoint you, and you're not going to hate me. But for the person who says, hey, I can barely afford it, and it has to be exceptional, but I don't want surgery. That's the kind,
That's unrealistic.
That's a very different set of circumstances. So, during the interview process, I always tell patients, you're interviewing me, but I'm also interviewing you.
Yeah.
That's good.
And I'm trying to figure out, are you somebody that I can operate on? Somebody that, number one, has realistic expectations. Somebody who's really listening to the pros and cons of surgery, the risks and complications, everything I'm telling you, and realistic outcomes. Because you can't come in at 60 and show me, photos of a bikini model on a beach who's 20 and then hold me accountable to that, right? Like, we have to be on the same page about what I can do for you. You can't just make anything you want. It doesn't work that way.
That's why the consultation is so important.
Yeah.
Well, and I have to actually, so I know I said I wanted a lift, but I have to do a full-blown tummy tuck and hernia repair at the same time. So I need surgery. I know as a former trainer, I cannot repair this, in the abdominal region.
Sure.
So if I were to do the tummy tuck, it's best to do it with the breast lift, right? To do it all in one?
So it's a good question. It comes up a lot. So when we do something, there's this term, mommy makeover. It's been around.
Yes.
So mommy maker usually means you're doing some version of breast surgery, whatever it is, and some version of body surgery. And it's usually implants and a lift, or implants and then tummy tuck with or without areas of liposuction. So that's pretty common. Now, in terms of what's best, I think it's certainly the most convenient thing to do it all at once.
Right.
Right. One anesthesia, one recovery. Then the other part is, the question is safety, right? The more things we add, the longer the surgical time becomes. Adding tummy tuck, when you talk about surgery, there has to be something that's associated with the highest complication rate and something associated with the lowest. Even if it's all relatively low, there's still a highest and the lowest.
Okay.
And tummy tuck tends to have is on the higher risk end, and then things like facelifts tend to be on the lower end of the spectrum. So, and we know that combination increases your risk a little bit. So the question is, has anybody ever done a phenomenal study where the level of evidence is really high and irrefutable, where you operate on 1,000 patients who are all matched for all the different criteria that you would match in a study, all variables, to say, here's, a mommy makeover in one stage versus two stage. It's a hard study to do because patient populations are not homogeneous. There's all kinds of variables in there, whether it's age, medical conditions, there are a lot of, and then surgeons, and then sites you operate. There's
I don't know how you would do that study.
But what I would say is, most of us will do combination surgery.
Okay.
I do it frequently. Fortunately, we've always had very good luck because we pick healthy patients. We bring their doctor in right away to say, okay, we want this patient optimized in their best possible condition for surgery. And then all the things that we do afterwards to encourage them to recover well, getting up and walking to avoid blood clots. There's a lot of things that we do. I mean, at the end of the day, everything is about, it's safety first, aesthetic second.
Okay.
I mean, they're both right there, but I won't do anybody's aesthetic surgery if I have the remotest sense that they're if there's low, moderate, and high risk is a general way of thinking about it. Low, easy. Once you talk about moderate, it's a little bit more of a conversation, and high risk is never an option.
Okay.
So, but safety always comes first. I mean, I think that if you have appendicitis, we don't have the luxury of saying, oh, you're a sick patient, we shouldn't operate on you.
Right.
Or you're a gunshot patient. You have to go to the OR, and you may be operating on somebody you don't really want to. With aesthetic surgery, I think the bar has to be a lot higher to avoiding complications, because if you're essentially doing something that somebody doesn't need, so you really have to front load safety.
Okay.
Who
that
falls
makes
into
sense.
those categories though? You said high risk, moderate,
Oh,
and
well,
low.
that's so
Yes.
right. What are their comorbidities? So do they have diabetes? Is it well controlled or is it not well controlled? Are they smokers? Do they have hypertension? There's a lot, anything that sets them up to be a natural, to not be a good at wound healing, right? They have collagen vascular disorders. What medications are? There's a lot of different things to look at. Right now, the big thing is like Ozempic and other weight loss meds.
Oh.
Back in the day, it was fen-phen or any product with phentermine. So, the medications that they're on sometimes have to be adjusted. Sometimes they have to be stopped. And I don't think, have any business doing that because, yes, we all go through med school and we all go through residency. And there was times as a plastic surgery resident where you're running an ICU. So we do train in taking care of some of the sickest patients that there are. But then you stop doing that. And then you're not going to be good at it. And then you stop managing healthy patients with medical problems because you cut and sew for a living.
Oh.
So what most of us do is we rely on the primary care physicians or the OBG, whoever's that person's main physician. We rely on them for medical clearance. So in my practice, I've always been pretty conservative. Anybody 40 and over, we need a note from the doctor. If they have, if they're seeing an endocrinologist, then we want that person's note. If they're seeing a cardiologist, we want that person's note. So we get a lot of data, and then we make an internal decision. The outside referring doctors also influence that decision. And if they ever say no, that's a hard no. If they say yes, but we say no, that's a no. Or if those two parties say yes, but the anesthesiologist brings up issues because they get the data before the case, right? And because that person has to put the patient to sleep,
Yeah.
wake them up. So there's a lot of levels of different physicians looking at it to try to avoid mishaps, right? You don't want to, you can't avoid everything, but you really want to set the bar high so that you have the highest probability of getting good, safe outcomes.
Do you like it when patients bring in pictures though?
I tell them that we try to get them. That's one of the things they're told is bring in your wish pics. I always tell people like there should be a theme, right? Like if you come in and you're a breast augmentation patient and you've got one patient who's built like this and one like this, like that's two very different outcomes.
Right.
So I always tell people there should be a theme. Whether it's 2 photos or 100, please don't bring 100. It's too many to look at. But
Sure.
there should be a kind of a fairly consistent theme,
Okay.
right? And it forces the patient to say, okay, what do I really want? Right? Because you could describe in words, well, I want a conservative result. Well, some people's conservative is this and some is this.
Right.
Yeah.
But a photo shows you kind of everything.
Right.
So, in some ways, if you come in, as long as I've seen your photos and your wish pics, that gives me, let's say 90%. But then what we filter in is, what are the words you used? And are the words consistent with the photos you showed me? And, like, what are you trying to avoid? What are the things that are really important to you to get out of it? What are the things that are super important for me not to do for you? Right? Because sometimes just as important, like if people say, like, I really don't want to look like a, fake.
Right.
I don't.
Yeah,
Or
the
when
natural.
I'm an attorney. When I show up in a court, I don't want anybody to really notice it. Okay, so that tells me, okay, conservative change. Make sure that only people are going to notice depending on the clothes that you wear, which might be a Friday night under certain circumstances when you're out with your friends or a date or something.
Right.
Okay.
But you in your professional life don't want anybody saying a word. Okay, there's an easy plan for that.
Yeah.
And then people walk and say, okay, when I go to work or when I walk into a bar, I want the music to stop and everybody to turn and say, wow,
Gas.
where'd you do that?
Uh-oh. Yeah.
Right? And
Stunning.
that is like, that's
Yeah.
the range of requests that you get.
Right.
Thank you so much for joining us and being part of our growing community.
Stay tuned for new Care Expert episodes every Wednesday. And don't forget to subscribe on your favorite podcast app and YouTube. Hey there, don't leave yet. Just wanted to say if you want to hear more about health and wellness, check out these episodes of Care Experts. Also, before you go, make sure you like and subscribe.